My name is Armando Moreno. I'm a OMS3 from the University of Incarnate Word School of Osteopathic Medicine, and I am presenting on behalf of myself and student Dr. Tyler Tepfenhart on pulmonary vein thrombosis and the importance of zebras. This case presentation is on a patient that we both saw together who had a pulmonary vein thrombosis of possible traumatic etiology. Pulmonary vein thrombosis is a clinically infrequent yet potentially fatal condition in which a thrombi forms in the pulmonary veins. It's potentially dangerous due to the risk of forming a thromboembolism, which can lead to stroke, ischemia, or infarction. It is usually associated with malignancy, but other common etiologies are post-surgery complication and atrial fibrillation. Patients are usually asymptomatic, but can present with symptoms similar to pulmonary embolism. That can be identified using several imaging modalities such as transthoracic echocardiogram or transesophageal, computed tomography, or magnetic resonance imaging. Treatment is centered around anticoagulation so long as there are no contraindications. And we are presenting a case of idiopathic PVT that is suspicious for a possible traumatic etiology, and also discussing the impact it had on us as osteopathic medical students and future physicians. This patient was a 54-year-old woman with a history of anxiety, fibromyalgia, COPD, and tobacco abuse, who was admitted after about 1 week of right-sided chest pain that was acutely worsening with a non-productive cough and dyspnea. The pain was described as burning and 10 out of 10, worse with coughing and breathing, and described as withholding the patient from being able to fully cough, as she has been used to a chronic cough with her history of COPD and smoking. She did not endorse any other symptoms, including fever, palpitations, or hemoptysis. Denied any personal history of arrhythmia, recent surgeries, coagulopathies, DVT, stroke, hypertension, hyperlipidemia, or diabetes. Her family history was significant for coronary artery disease in her mother and leukemia in her father, but both were still living. She lives with her boyfriend, works in retail, smokes about a pack a day, and denies drinking and drug use. Upon a further interview to determine possible etiologies, the patient reported being struck in the chest by her son prior to the onset of her symptoms, which raised our suspicion for a possible traumatic etiology. Her initial presentation demonstrated normal vital signs, temperature of 97.9, heart rate 69, respiratory rate 18, blood pressure 134/79, and 98% oxygenation on room air. She was in no distress, had normal capillary refill and heart sounds, clear auscultation bilaterally. Her chief complaint of chest pain was reproducible with application of mild to moderate pressure on the right anterior chest wall. Otherwise, the remainder of the exam was unremarkable. An initial workup included an ACS workup, troponin and EKG, both normal, and then rapid CT to rule out the possibility of a pulmonary embolism. The imaging demonstrated pulmonary venous thrombosis in the right posterolateral pulmonary vein without evidence of embolism, lymphadenopathy, or other acute findings. The images on the right are those that were found in the literature demonstrating similar findings, but in the right superior pulmonary vein and the right inferior pulmonary vein versus the posterolateral in our patient. The CBC and CMP within normal limits, hemoglobin A1C 5.5, magnesium, phosphorus, and calcium with normal, lipid panels unremarkable, TSH 0.24, INR 1.3, rapid COVID RNA negative, all performed under the recommendations of a pulmonology consult to pursue possible etiologies for the pulmonary vein thrombosis. As stated, pulmonology was consulted, who recommended anticoagulation as if treating a DVT or PE, with also inclusion of monitoring telemetry and SpO2 and supportive care as needed. As such, the patient was started on Lovenox, 60 milligrams, Q12 hours. There were also standing orders for antitussives and analgesics as needed and continuous monitoring. Within 24 hours, the patient had significant improvement in her symptoms, with her pain decreasing from a 10 to a 3 out of 10. They also reported improvement in dyspnea and cough, and such that they were able to fully cough now, as they were used to prior to onset of these symptoms. With the patient's significant clinical improvement and at their request, with the approval of pulmonology, the patient was discharged with scheduled follow-up. She was discharged in apixaban 10 milligrams by mouth twice a day for 7 days, to be followed by 5 milligrams by mouth twice a day for 3 to 6 months at the discretion of her follow-up with primary care and pulmonology. This is the standard treatment for DVT or PE on the outpatient basis. We'll now discuss a bit on the noteworthiness of this case and its large value and impact on us as current students and future physicians. In terms of how this is a relatively novel case, historically PVT is rarely reported, and blunt force trauma, as was concerning in this case, is even less common of a cause. Most commonly, as previously stated, it's related to malignancy, AFib, or as a post-surgery complication due to alterations in Virchow's triad. There's even been a recent connection to COVID-19 as a possible complication of infection. These are also usually asymptomatic, but can present similarly to pulmonary embolism, such as hemoptysis, hypotension, worsening oxygenation. However, in this patient, all that was seen was reproducible chest wall pain and dyspnea. On physical exam, the patient was not hypotensive, did not have worsening oxygenation, was not hypercapnic, had no fever, and otherwise the only remarkable feature was the reproducible chest wall pain. As far as we were able to find in our review of existing literature, this is an atypical presentation for PVT. In terms of how this provides value in future practice, specifically for us as students, we'd like to comment on how this relatively novel case serves to emphasize the importance of labeling ourselves as lifelong learners, especially considering the ever-growing base of medical knowledge. It is important for us to maintain and reinforce our understandings of underlying mechanisms of pathophysiology, especially in a case such as this where the pathophysiology is relatively the same for a variety of conditions. This baseline understanding will enable us to, if we encounter such rare or previously unknown to us conditions, that it gives us a guide to appropriate treatment of a condition where there is no gold standard, such as PVT. Secondly, it serves as an example of the fact that what we are commonly taught in medical school curriculum is not always what we'll see. And what we're not taught is still important to educate ourselves on and grow comfortable with, especially if it's something that is growing in prevalence due to new diagnostic capabilities. And then as current just students and doing a reflection of how this has impacted us and how it makes us see how far along we've come as third-year students, it reminded us that as preclinical students, a lot of the education seems to center around what are known as zebras. This refers to a colloquial medical take on Occam's razor in the adage of when you hear hoofbeats, think horses, not zebras. This is especially relevant as a lot of the physiology and pathophysiology we're taught is commonly in the context of such zebras. And then it's quite easy as a medical student to realize that since we're being taught on zebras, to kind of discount that teaching and grow frustrated with being expected to recognize pathologies that we may never see. But it is our hope that either through this presentation and discussion or through their own clinical experiences, our peers are learning to not only appreciate the zebras and their importance, but also continue to label themselves as lifelong learners. That is the end of this presentation. I would like to thank student Dr. Tyler Tepfenhart for his help in a significant portion of the research and writing and design of this presentation, and to our attending with whom we saw this patient, Dr. Brandon Perry. Thank you.